This talk considers the responsibilities of the National Health Service for what is known as continuing healthcare funding. Continuing healthcare funding is when somebody's health and social care needs, the totality of them, fall to be funded by the NHS. This talk considers the position in England and Wales, and it looks at adults. The law relating to children is slightly different, and it's dealt with in the resources and links listed at the end of this talk. The talk is divided into 6 sections. It commences with an introduction to the key legislation. Part 2 is the history of the relevant policy developments. Part 3 is a description of the series of court and ombudsman's cases, which will be referred to as the benchmark cases. Part 4 is a review of the key guidance that's been issued in England and Wales. Part 5 is a look at a mechanism known as the decision support tool that's used to help decide if a person is entitled to NHS continuing care funding. And the final part, part 6, the final section, details resources and links, follow-up material for more in-depth study. NHS continuing care concerns a territorial clash between 2 major statutes passed at the end of the Second World War. They're giant statutes. One is referred to as the Health Statute, which is the NHS Act. And that Act cost the British taxpayer almost £120 billion a year. The other Act, which is the Social Care Statute, in 1948 was an act referred to as the National Assistance Act. And that is also a major piece of legislation. It's the obligation on social services to provide social care for elderly and disabled people. And that costs the British people, the taxpayer and private individuals, about £20 billion a year. Now, there's a point at which somebody ceases to be the responsibility of social services and they fall to be the responsibility of the NHS. Why is that important? Well, that's important for individuals for one particular reason, and that is money. The Social Care Statute has always been means tested, so people who have capital or income above a certain rate have to pay for their social care services, whereas the NHS statute has always been free at the point of need. So if you are, for instance, an elderly person who's accumulated assets over your life and you become frail and elderly and you need a substantial amount of care, you might want to argue that you're the responsibility of the NHS, that you should be receiving NHS continuing healthcare funding, because if you get it from social services, you may have to use all your resources to pay for that care. Now, there's an important point to realise from what I've just said, is that the responsibility is basically a clash between the Health Service Act and the Social Services Act. This is a legal question. Whether you're entitled to NHS continuing care is a matter of law, not of policy. And so we have really 3 key issues in this area. Firstly, that it's regulated by the law. It's a lawyer's decision ultimately. Secondly, that the law unfortunately gives us only a general steer on who is responsible, and we will look at that shortly. Because the statute law is only brief in its reference to this divide, we then have to look at the third issue, which is what the courts and the Ombudsman have said about where the line is, where somebody goes above a certain line and becomes the responsibility of the health service. The point I've just made is that this is an area regulated by the law. And I'll give you an example which I think illustrates that point. Often I would suggest that it's a bit like the rules of Scrabble. We all play Scrabble, but what we don't realise is that every family plays it slightly differently. Every family will have a different rule for what you do with the blank piece. Some people will allow certain words and some people won't allow words. But when you have a dispute about whether something is permitted or not, you have to go to the rules. And that's what we do in law. The example that I'd give is a fairly common one. If you're an elderly person with, say, Alzheimer's disease, you have challenging behaviour, you have very severe health and social care needs, but primarily your problem is that you have very challenging behaviour. You are more likely to get funded by the NHS under NHS continuing healthcare than if you had exactly the same symptoms, but those symptoms arose from learning disability. You have challenging behaviour, you have severe health and social care needs. And so sometimes you say to healthcare colleagues, why should somebody not get continuing healthcare funding when they've got learning disabilities and get it when they've got Alzheimer's disease? And the response often is, well, Alzheimer's disease is an illness, whereas, of course, learning disability is not an illness. That's the case in terms of the general view of matters. About 35 years ago, in the United Kingdom, we came to the conclusion that learning disability was largely a social issue, not a health issue. 35 years ago, most people with learning disabilities were considered to be ill. 20% of them lived their whole lives within mental handicap hospitals, pretty awful places. 35 years ago, the average life expectancy of somebody with learning disabilities was less than 20 years. So there have been huge changes in attitude in the last 35 years. We now don't see learning disability as an illness. But to a lawyer, we say, well, what's the definition of an illness? And if you go to the legislation, which is in the National Health Services Act, it's also in the National Health Services Act, Wales Act, there are two statutes. We see that Section 275 of the English Act, or Section 206 of the Welsh Act, defines an illness, and it says that an illness includes a mental disorder within the meaning of the Mental Health Act, 1983, and any injury or disability requiring medical or dental treatment or nursing. So an illness includes a mental disorder, so we need to know what the definition of a mental disorder is, and the Mental Health Act 1983 tells us that a mental disorder means a disorder or disability of the mind. So at law, the definition encompasses learning disability. A learning disabled person is ill as a matter of law, not as a matter of common parlance. And that means that if a health body is treating people with learning disabilities differently to somebody with Alzheimer's disease, they're breaking the law because these people are ill, and they're probably breaking the law in relation to the Equalities Act as well. These are important issues, and that is why we must keep returning to the law in these issues, not what practice has gone on in this particular area or other. Huge differences arise between different health bodies and different regions, just as huge differences arise between families in the way they play Scrabble. Ultimately, however, we need to look at the rule book, and that's the purpose of this talk. The clash between the two statutes that are referred to occurred as a result of two acts that came into force on the 5th of July 1948. The Health Statute, the NHS Act 1946, placed an obligation on health bodies to provide accommodation for ill people, hospitals. The Social Care Statute, the National Assistance Act 1948, placed a duty on social services authorities to provide accommodation for elderly, ill and disabled people. These are care homes, they used to be workhouses. So we've enacted in 1948 two statutes that place responsibility on two different public bodies to accommodate the same group of people, ill people. So how do you decide whether somebody goes into the health service hospital as it was in 1948 or the social care home as it was in 1948 run by the social services authorities? Why do you care? Well, as I've already said, you would care if you had to pay for that because the health provision would be free. It's also a very important point for social services authorities and the NHS because if it comes out of their budget, clearly it's going to have an impact. Whereas if they could shunt the cost to the other body, then they would make significant savings. Now, curiously, in 1948, this wasn't a particular problem. It wasn't a problem for two reasons. The first reason is that very few people fell into means testing in 1948. Capital means testing, where people have savings above the threshold, has only become a problem in the second half of the 20th century and the 21st century. That problem occurs because people start acquiring houses. 1948, hardly anybody had inherited wealth. It was just something that the very wealthy had. But in the 70s and 80s, and curiously the 90s, as we'll see, home ownership takes off in a big way. And so increasingly large numbers of people have capital assets that take them above the funding threshold, and therefore means that they have to pay for the care themselves rather than getting it from social services. The other big change that's happened since 1948, and people forget this, is the loss of beds from the NHS. In 1948, the NHS had very large numbers of beds. There were huge mental hospitals and mental handicap hospitals in the countryside, and they weren't just accommodating mentally ill people or people with learning disabilities. We had large numbers of hospital beds because of the war, because of the people injured in the bombing and soldiers abroad. But what is often forgotten is that 35 years ago, half of all general hospitals, half of their patients were long-stay patients. Until, in my terms, relatively recently, general hospitals warehoused people with dementia. They had hutted wards where large numbers of people with dementia were placed. In fact, the way you decided whether somebody was health funded or social care funded was to ask whether they were continent. If you were confused elderly continent, you went into a social care home under the National Assistance Act. Whereas if you were confused elderly incontinent, you went into one of these large hutted wards in general hospitals. They weren't very pleasant places, but that's how the arrangement happened. Now in the 80s, and this talk doesn't have time to look at that, we lost the beds from the NHS. We closed the mental handicapped hospitals and the mental illness hospitals to our credit, and we closed almost all of these dementia wards. So today, the average general hospital will have no patients long stay. Whereas, as I say, 35 years ago, just over half of their patients would have been long stay. And this rapid change occurred in the 1980s, and it coincided with the growth in the number of people who became what were called self-funders. They ceased to be helped by social services because they had capital assets. Now, a significant number of those had acquired their capital asset because they had bought their council house. And so you have this phenomenon in the 80s of people who voted for Margaret Thatcher, who'd done well under the Thatcher regime because they had acquired an asset, perhaps for the first time in the history of their family, going back to feudal times, something that they could hand down to their children. And then they fall ill at the end of the 80s and the early 90s, and they're told that they will have to use that asset to pay for their care. And they can remember that within a recent period, their relatives had had that free in an NHS ward. But they're told there are no NHS wards anymore, that they will have to go and find a nursing home, and they will have to pay with their capital asset, their home. They'll have to sell their home to pay for that. And they were not happy. There was a big issue in the early 90s. People started saying the NHS is not safe with the Tories, because although people had done well under the Tories in terms of acquiring capital assets, the safety net of the NHS had been withdrawn. The law hadn't effectively changed since 1948, so one could ask why the people that had to pay for their nursing homes, who previously got it free, didn't take legal action. And we'll see that some of the people have taken legal action concerning this matter, but the majority of people have tended to go to the Ombudsman. And the reason for that is simply cost. If you have assets below the funding level for social care, then you don't really care because you will get your social care and healthcare needs at the same cost, whether it's provided by the NHS or social services. But if you have assets above the capital maximum, then you're going to be very keen to have it from the NHS. If you have assets above the capital maximum, you're not going to get legal aid. You're going to have to fund it yourself. And nobody really, very few people are going to take that risk of litigation. So we tend to see quite a lot of cases going to the Ombudsman on this matter, purely because the Ombudsman's procedure is free. You can only access it once you've gone through all the complaints procedures. We're now going to look at what I would call the benchmark cases. The first case that really hits the headlines is a case in 1994. It's called the Leeds Ombudsman case, and it concerns a man in his late 50s who'd had a series of strokes. He'd stabilised and he was in the Leeds Royal Infirmary. He'd been in the Leeds Royal Infirmary for 20 months when this matter came to a head. His wife was effectively cajoled into getting him discharged. The NHS started saying things like, "You're bed blocking," because of course it was during the 80s that the beds had gone from general hospitals such as the Leeds Royal Infirmary. She discharged her husband eventually to a nursing home, but then she realised she had to pay for that, and she made a complaint eventually to the NHS Ombudsman, Sir William Reed, saying, "Look, my husband is very ill. He's got hardly any mental or physical capacity. He's got a kidney tumour, although that's being dealt with palliatively. It's a sign of his illness. He has hardly any mental comprehension. He needs moving, turning, and so on. He's ill." And I thought the NHS was there for people like my husband. He's paid into the NHS all his life. And the Ombudsman agreed. And the Ombudsman published this as a special report. And it was agreed that the Leeds Health Authority would refund the patient and his wife the costs of the nursing home, and that he was to be funded on a continuing care basis. This is a very important case because we need to remember the facts. This man is stable. He's been like this for 20 months. He's not in touch with any specialist healthcare team. He's being dealt with by an ordinary nursing home, and they don't need any external inputs. They can deal with him adequately. He needed effectively, a lot of low-level nursing, turning, making sure that he didn't develop bed sores, or the other treatment that he had for his kidney tumour, and he also had some epileptic fits, but those again were being dealt with, like the tumour, with just medication. This case got a great deal of prominence in the national newspapers in 1994 because the NHS was in a relatively bad way at that stage. Waiting lists were going up. NHS was one of the major issues that the John Major government had to face. There was a lot of disquiet about this, and the health secretary at the time was under great pressure. And she said that she would issue it. She would address this issue, and she would issue guidance. And she did in 1995 issue guidance on who should be the responsibility of the NHS and who should be the responsibility of social services. Since that time, we've been governed largely by guidance. There's been guidance issued, the 1995 guidance, and in 2001, and in Wales in 2004. And today we have guidance in Wales of 2010 and in England of 2012. What we have to realise, however, is guidance is not law. Guidance is there to explain the law. The law is what is in the social care statute and the NHS statute. The law is in what the courts say, and to a degree what the Ombudsman says, because the government accepts that the law should comply with the Ombudsman's findings. What does the law say? The original statute, the National Assistance Act, 1948, Section 21, subsection 8, says something very interesting. It says that Where a service could be provided by the NHS under the NHS statute, then it can't be provided by social services. The social services statute is the statute of last resort. The NHS statute is the dominant statute. In fact, if you read that provision literally, it means that it's unlawful for social services to fund something that could be funded by the NHS. Now, Section 21, subsection 8 of the National Assistance Act is to be repealed and reenacted in England and Wales in what will become the Care Act and the Social Services and Wellbeing Act in Wales. But both of those statutes replicate this provision precisely. And so the law is, and it will be, that social services cannot fund somebody if that person could be funded by the NHS. And for the purposes of this talk, I'll call that the Section 21, subsection 8 line, the point at which somebody ceases to be the responsibility of social services. It's a curious factor that deciding whether somebody is health or social care responsibility is actually a social care decision. The NHS can fund really anybody who has health or social care needs. The Act is very broad. It's the social care statute that says there is a limit beyond which social services can't go. Although the John Major government did take steps to issue guidance concerning continuing care and did try to rein back the losses of NHS beds, of course, it was too late. They lost the election in 1997 and Labour came to power. Labour came to power with really one promise and only one promise on the NHS, and that was that they would cut waiting lists. And waiting lists were a very major problem. They were the political issue in 1997. Now, putting money into continuing care is not going to help waiting lists. In fact, it's going to do the opposite. And so we see for the first 10 years of the Labour government that they did really nothing on NHS continuing care. In fact, I think that they were very unhelpful. And so we have to wait for events because we're not seeing any input from the government. The event that happens, which is really the key case in this area, and that case happens in 1999, is the second benchmark case, and that's the case of Pam Cochrane. The facts of her case are crucially important. Pamela had a terrible accident when she was quite young. She was crossing the road and she was hit by a car and she had massive head and physical injuries. She wasn't expected to live. She had total severance of the spinal cord between cord 5 and 6. She has upper arm use to a degree. She has good arm use in one arm and not so good in the other arm. So she can, to a degree, cooperate on being hoisted, for instance, to a degree. But below that level, because of her spinal cord injury, she's paralysed, she's tetraplegic. And as a consequence, she's doubly incontinent. She has a catheter. She has some breathing difficulties, although Pam is not on permanent oxygen, and one would very rarely see her on oxygen. She does have oxygen in the morning and she does wear a tight vest to help her. But as you'll see from the videos at the end of this talk, she can speak very freely and with great passion and without obvious difficulty. Pam has headaches too because of her head injuries, but those are dealt with by analgesics. And intellectually, she made a complete recovery over time. But of course, you don't get over tetraplegia. And so she remains with those impairments. For very many years, Pam lived in hospital accommodation in Exeter with a number of other people with similar impairments, people with physical impairments largely, some with sort of progressive conditions. And at the beginning of the 90s, the health authority said to Pam that effectively they didn't consider her to be their responsibility. They considered that she didn't need a great deal in terms of health care. She needed her catheter changing She needed a bit of oxygen and she needed hoisting, but beyond that, she didn't need a great deal of what one would call classic healthcare, and that she was the responsibility of social services. Now, Pam is a very courageous person indeed, and she used her personal injury money. She used a large amount of her money to take this matter to court, and she went to the High Court. She won in the High Court. That was appealed by the Health Authority and by the Department of Health, and she went to the Court of Appeal. She had an exceptional lawyer and an exceptional legal team, and the Court of Appeal found in her favour. She got her costs back, so that is a great relief. And the Court of Appeal tried to explain what they thought, they did explain very clearly where the boundary lies between health and social services responsibilities. They said in borderline cases, it will depend upon a careful appraisal of the facts. And that's where the decision support tool, which is what we'll look at in part 5 of this talk, comes in. But as a general indication, they said, there are just 2 factors. And if these 2 factors exist, then social services can fund somebody like Pam. It would not be unlawful. But if either of these factors don't exist, then it would be unlawful for social services to be the funding agency. It would have to be the NHS. And the 2 factors are these. The first one is that they said, if the social care, if the healthcare you need is merely incidental or ancillary to the provision of accommodation, then social services can fund that. Now, courts use words very carefully. That's really all lawyers have. Words. Merely incidental or ancillary. What does that mean? Well, in ordinary parlance, it means marginal. Something that's merely incidental isn't the main issue. It's not even one of the operating issues. It's a marginal, it's a minor issue. The court was using it in terms of quantity. And what they're saying is merely incidental or ancillary is a small amount. It's a minor, marginal amount of care. If you're having a small amount of healthcare, then social services could fund it if your primary need was social care. But they said the other factor is that the care that you get must be of a nature that you would expect a social services authority to provide. Effectively, a nature that you would expect a social care assistant or an auxiliary nurse perhaps to provide. But if it was more than low level in terms of its nature, its quality, then social services couldn't fund it. So the court said it's just effectively, quite simply, a quality-quantity test. If the quality of the care you need, the health care you need, is low, and if the quantity is low, then social care can fund it, the social services can fund it. But if either of those factors don't exist, then it must be funded by the NHS. Now, one can say, well, that's very interesting, but that's quite theoretical. Give us a practical example of what is low level in terms of quality, quantity, or what isn't. And I think the most interesting thing about the Cochrane judgment is paragraph 118, where the court look at Pam and they say, is she getting social care or health care that's of a low level in terms of quality and quantity? As I've said, she's not getting a great deal. Pam is hoisted from her bed to her specialist wheelchair each day. She is getting a bit of oxygen first thing in the morning, most mornings, and she is having to have her catheter sorted by a nurse. But beyond that, Pam is, if you go into her accommodation, it's very much like a student accommodation as far as I can see. It's got books and it's got computers and it's got, work that she studies. She's a great campaigner, a great emailer. She isn't getting a great deal in terms of healthcare, in my opinion. But at paragraph 118 of the judgment, the Court of Appeal said that Miss Cochrane needs services of a wholly different kind, that she was well outside what social services could fund. She was well into the territory of the NHS. She's not, in the court's opinion, a borderline case. Well, that was quite a devastating judgment, because that continued from the Leeds Ombudsman case to suggest that people with quite modest healthcare needs should be funded by the NHS, which might seem radical today, but of course, as I've already said, 35 years ago, half of all people in a general hospital with conditions like the man in Leeds or Pam Cochrane were being funded fully by the NHS. So Pam Cochrane is the second benchmark test. It's law, it's the Court of Appeal, and it therefore trumps any guidance that's been issued since that time. But what we'll see that the guidance in England and Wales does chime and does reinforce what was said by the Cochrane decision. Now, in the notes, you'll have 3 other benchmark cases, and I'm not going to go into them in detail in this talk. We'll see that in 2004, there was a decision issued, or a report issued by the NHS Ombudsman in England concerning a woman cared for in the Wigan and Bolton Health Authority area. And she had a series of strokes. She couldn't speak, she couldn't comprehend, and she actually had a tube into her stomach, a PEG tube. And the Ombudsman expressed disbelief that this woman hadn't been funded by the NHS. She found it incomprehensible. In her opinion, and she likened the situation to Pamela Cochrane. She used Pamela Cochrane as a benchmark case and said this woman could. It was inconceivable to suggest that the health response to that woman's needs was merely incidental or ancillary, or of a nature which you could expect social services to fund. The fourth benchmark case is a case called Poynton, which is a man with Alzheimer's disease in the Cambridge area. And he's got challenging behaviour, but he's cared for by his wife, and she employs 2 or 3 care assistants to look after him, largely to deal with his challenging behaviour. She'd asked for assistance from the health body, but they had refused because they said he couldn't be continuing care because there were no nurses. There was no health input at all. It was all being dealt with by Mrs. Poynton, Barbara Poynton, and her care assistants, and none of them were nurses, were qualified nurses or qualified care assistants. And so he was getting, in their opinion, no health inputs, quality or quantity. And the Ombudsman said that that really is not the issue. It's what he needs, not what he's getting. And in her opinion, the specialist skills you had to deal with somebody with challenging behaviour were not those you would expect from the average care assistant or auxiliary nurse. They were of a nature that took him above the Cochrane test. They were of a nature that would fall to be dealt with by the NHS. So Mr. Poynton was held to be entitled to continuing health care. He's important because he was living at home. The Ombudsman, as the Court of Appeal had said in Cochrane, reiterated, where you are is irrelevant. The setting is not determinative, and who provides the care is not determinative. It's not relevant at all. So you could be living at home and not having any contact with the health service, but still entitled to continuing health care. In this case, what Mrs. Poynton wanted was some respite care every 4th or 5th week. And that, because Mr. Poynton was continuing care, would have to have been funded by the health authority. The 5th benchmark case concerns a young girl in Haringey who had a congenital difficulty that required her to have a breathing tube inserted down her throat. That was done by the Great Ormond Street Clinic, and she was discharged home, and her mother was trained, as many mothers are, to suction these tubes out, because if they become blocked, they're very dangerous. Now, the mother had another disabled child, and so she needed some respite care because she had to do the suctioning at night as well. And the question fell to be determined whether the respite care should be funded by the Social Care Authority or the Health Authority. And the High Court, in this case, said that although the mother was doing this, and it was something that a carer would often be doing. It wasn't something that you would expect a care assistant or an auxiliary nurse to do, that it was of a nature outside what social services could do, and therefore the child was the responsibility of the health body in Haringey. So we've seen a range of cases in the benchmark cases, people living in the community, people being cared for just by their families, people who are stable, people who have a variety of conditions, swallowing conditions, peg tubes and things like this. And those are useful when we come to look at a decision support tool in particular, which we're going to look at in part 5 of this talk. We've seen a series of benchmark cases where the courts and Ombudsman are laying down a fairly consistent line above which social services funding can't go. Until the second half of the first decade of the 21st century, we saw very little involvement by the government. But in 2007, the English government issued guidance, and in 2010, similar guidance was issued in Wales. So the guidance I'm going to talk about now stems from that period. It's now been revised in England, so it's 2012 guidance, but the 2010 guidance still exists in Wales. I'm largely going to be looking at the English guidance because the Welsh guidance is taken as a copy from that. The differences are very minor. And the guidance is welcome and it's good guidance, and it says a number of points that I think we need to take particular regard to. And so I'm going to refer in this section to 3 very important parts of that guidance. The first important point the guidance makes is that the setting of your care and who does it are irrelevant. These are points that have come out from the Court and Ombudsman's decisions. You can get continuing care in an ordinary care home, in a nursing care home, in your own home, in a hospice. Where you are, it doesn't matter. The characteristics of the person that provides the care are also not relevant. It could be your mother, your daughter, your sister, your brother. It could be a social care assistant. The second very important point, and it's almost sometimes I think one of the most important points of the framework guidance says, is that well-managed need is still need. What does that mean? What it means is that, let's, for instance, say that I'm somebody with learning disabilities and I'm extremely challenging. I fly off the handle for no particular reason. And on occasions, I need 2-to-1 care, two care assistants to control me. I always need somebody with me. I'm a very difficult person indeed. And say I'm then placed in a care environment where the people looking after me have got applied behavioural skills and they anticipate all the triggers that make me become violent. And because of that management regime, I become a complete sweetie, and I don't have any challenging episodes anymore, and I become a very easy person to deal with. Now, in those situations, not infrequently, the NHS will say, well, this person is no longer entitled to continuing health care because they're not challenging anymore. But of course the answer is, I am challenging. It's just that my challenge behaviour is well managed. Well managed need is still need. And so you have to say, would this person be okay if you took away that care management regime? And the guidance goes on to say, if the management regime has permanently removed or reduced the need, it might have a bearing. But if you took me out of that management regime and I would revert to the challenging person that I was, then it must be completely ignored. It's not a question of whether there have been any incidents or whether there have been any crises. The question is this person well managed? If they are well managed, you look at them as they would be without that management regime. The third aspect of the framework guidance in both England and Wales that I think is particularly important is a paragraph that summarises the reasons why NHS cannot be refused. Effectively, what that paragraph says is that if you are going to refuse NHS continuing care, well, then you are entitled to do that, but you can't use any of the reasons specified in that paragraph. Now, you'll see a slide coming up which shows that the English paragraph, it's present also in similar terms in the Welsh guidance. And you'll see that that summarises the points that we've already made, that effectively where you are is not relevant, who is providing the care is not relevant, and the fact that the care is well managed is not relevant. You'll see that it also refers to the fact that you're getting NHS funded nursing care is not relevant, and that's a technical issue. If you're in a nursing home in England or Wales, then the health body will make a contribution. It's called an NHS funded contribution towards your nursing care needs in the region of £120 or so a week. And you can't get that contribution in a nursing home unless there's already been a decision that you're not entitled to NHS continuing care. So it's not relevant, because to say, well, you can't be continuing care because you're getting free nursing care is effectively putting the cart before the horse. We've now looked at the key parts of the framework guidance in England and Wales, and the fifth section, the part 5 of this talk, looks at one document that's attached to the framework guidance. In England, there are in fact 3 documents attached to the main framework guidance. One is called a checklist, which is to look at screening people to see whether they should have a full assessment. The idea is it screens out people that would never qualify for continuing healthcare. Another is a thing called a fast track pathway tool, which is designed for people who really are likely to die in the near future, and you shouldn't subject them to the full assessment process. Neither of those tools I'm going to look at in this talk, but there is further information about them at the end. What I'm going to concentrate on is a thing called a decision support tool, and that exists in England and Wales. The decision support tool is controversial because a number of people, myself including, think that it's defective. But it is a tool that has to be used. Both the English and the Welsh legislation effectively mandates its use. And I think that there's no reason why it shouldn't be used effectively. What one has to realise is the decision support tool is merely guidance. It's quite low-level guidance. And you couldn't use the decision support tool to have an outcome that conflicted with what the courts or the law has said, because what the courts say or what the statute says is law, and that's made by Parliament, and guidance can't effectively trump that. So we will use the decision support tool, but we'll have to realise that if the decision support tool conflicts with what the court has said in Cochrane, then we will have to follow what the court has said, not the outcome that the decision support tool is indicating. The most important thing to understand about a decision support tool is what in fact the Department of Health has said about it when it first issued it. When the Department of Health issued the decision support tool, it provided a PowerPoint pack, and one of those PowerPoints you'll see. What it says is effectively what the decision support tool is not. And there's 2 points on that slide that are very important. The first point that it makes is that it's not another assessment. It's not an assessment in itself. But it's the second point and the fourth point that I think is particularly important. It's not a decision-making tool. The decision support tool doesn't make decisions. It's not to be used mechanistically. It's not a question of counting up all the ticks. We'll see that there are critical bands and the severe bands and high bands. It's not a question of counting up those tick boxes. It's not a decision-making tool. The fourth point on that slide is also very important because it says that it's not a substitute for professional judgment. Effectively, the decision support tool is to be used as a way of collating information in an organised way. so that we have a consistent record of what a particular person needs. And we can, we'll look at that in some brief detail. Having collated that information, the practitioners, what we call the multidisciplinary team, which will normally be a social care employee and a health employee, go away and they apply what's called professional judgment. They think about the situation, they consider the benchmark cases and the law that I've already outlined, and they say, do they think the totality of this person's needs mean that they are NHS continuing care entitled or not? You don't add up, as I say, how many they've scored in this band or that band. The problem with the decision support tool is that although the Department of Health has told us very clearly it's not a decision-making tool, the guidance then goes on to say that if you do score one priority or two severes, or you have a severe and needs in a number of other domains, or a number of highs or moderates, then the inference would be you would be entitled to NHS continuing care. So immediately practitioners start using this mechanistically, saying, oh, have you got a priority? Have you got a severe? If you haven't got a two severes or one priority, you can't be continuing care. Now that's a complete misuse of the decision support tool, and it's causing very severe problems. So we're going to now look at a couple of the domains, and we're going to look at the totality of this decision support tool. But I can only look at it briefly, and as you'll see at the end of this talk, there are further references listed which will give you a very detailed analysis of each of the 12 domains in the decision support tool. So let us look first at the whole decision support tool and then look at one or two of the individual domains. You'll see the slide shows that there are in fact 12 domains on the decision support tool. On the left we see a column which is the breathing domain, then we have the cognition domain, then we have the psychological and emotional needs domain, we have a communication domain, a mobility domain, a nutrition, food and drug domain, and so on. There is a 12th domain, which is just a blank box, which is where you write all the information in that you think hasn't been properly dealt with in the other named domains. We'll look at some of the domains. As I say, at the end of this talk, there are references and a list of much more detailed material, but we'll just look at some of the domains. And let's look at the first domain, which is the behavioural domain. You'll see on that domain there is a priority, a severe, a high, a moderate, a low, and in fact there's a none as well. The priority says challenging behaviour of severity and or frequency that prevents an immediate and serious risk to self and or others. The risks are so serious that they require urgent and skilled response for safe care. If we use that mechanistically, what we're basically saying is that we've got to have one priority or two severes, because that's the indication given. But what is an immediate and serious risk? What is something that requires urgent and skilled response for safe care? Well, it's at that stage, when we're using our professional judgment, that we should look at the benchmark cases, and we should realise that Mr. Poynton needed he was held to be entitled to continuing care by the NHS Ombudsman. He had challenging behaviour, but that was dealt with by his wife and care assistants. Mr. Poynton was in fact in the advanced stages of his dementia, and so that some of his challenging behaviour, which had characterised the condition earlier, had diminished. So we would use him, and when we're trying to get a feel, basically, for what is an urgent and skilled response, what is an immediate risk, because the Ombudsman thought that that was enough to take him above the continuing care line. We'll see that the subsequent domains are cognition and so on. And what I want to show in this sort of final slide looking at the decision support tool is to run through the tool from the perspective of Pamela Cochrane. She is somebody that the Court of Appeals said needed services of a wholly different kind. She was well outside what could be funded by social services. If we look at her slide, or if we look at the decision support tool and consider her scores, it's quite an interesting scatter. What we see is that in terms of the behavioural domain, Pam will score nothing because her behaviour, she doesn't have any challenging behaviour. In terms of her cognition, she will also score nothing. She's extremely intelligent and alert. In terms of her psychological and emotional needs, she'll also score nothing. And in terms of communication, she'll score nothing because she is very capable indeed of communicating her needs. So for the first 4 domains, Pam scores nothing. In relation to her mobility domain, clearly she is immobile in the sense that she is paralysed. So you would expect her to score very highly on that. But if you actually look at the decision support tool, because she can cooperate to a degree with hoisting, it may be that she almost certainly only scores a moderate in that domain. If you run through further, in nutrition she's likely to score a low, in continence she will score a high. In skin and tissue issues it'll be a low, and so it will be in terms of breathing and drug therapies, and in terms of altered states of consciousness she'll score nothing. Now the decision support tool is saying to us, if we get 1 priority, you would expect somebody to continue in care. Well, Pam doesn't have a priority. If you get 2 severes, you would expect somebody to continue in care. But Pam doesn't have any severes. If you get 1 severe and needs in a number of other domains, you would expect that. Well, she doesn't have any severes, and she doesn't have a number of highs. But the Court of Appeal said that she needs services of a wholly different kind, wholly different nature. And how can that be? And of course the answer is that the decision support tool is not a decision-making tool. Even somebody with a scatter like that could well be entitled to continuing care. And if you were to use the decision support tool to refuse somebody in that situation, you would be breaking the law, because the Court of Appeal laid down the law in this case. The decision support tool is merely a piece of guidance issued in England and Wales that is supposed to assist you in coming to the same conclusion. The final section of this talk, part 6, is really a reference to further materials. In this talk, we haven't discussed the situation of children. There is guidance in England and Wales concerning NHS entitlement for continuing care for disabled children. That's a separate subject. Although the law is very similar, the position for children is such that they will always require some social care input. Once somebody's held entitled, once they're an adult and they're held entitled to NHS continuing care, all their health and social care needs are funded by the NHS. Social services are no longer in the picture. That's not true with disabled children, and there is a reference in the resources to 2 papers and articles concerning NHS continuing care entitlement for children. There are also materials relating to carers providing care for people who are entitled to NHS continuing care funding. Social services still have responsibilities towards those carers. There are further much more detailed materials in relation to the decision support tool and to the whole process generally, and particularly reviews, people who've been refused continuing healthcare and who wish to take that further. And also materials relating to disputes between health and social services. For individuals that wish to make to challenge an NHS continuing care decision, there are some very good resources. There's a good pack provided by Age UK, as it is now called. Also, Alzheimer's Disease Society has done an excellent guide, and so has the Spinal Injuries Association. There are also papers and articles that I've written on this subject, and those are on the slide that you'll now see. Well, I hope that this talk on NHS continuing care, which is one of a series of talks in the social care lecture series, has been of help, and that the resources listed at the end of this talk will enable you to find answers to any remaining questions that you have.